Welcome to 12 Lead EKG Acquisition and Interpretation Part 3, Acquisition and Interpretation. In Part 3, we are going to go over actual techniques for acquisition and interpretation, and this presentation is going to be embedded with more questions and answers to reinforce what you're learning. These are critical tools that you will need to properly identify changes in a 12 Lead EKG. So we hope you enjoy the presentation. In Section 5, we will visit the history of the EKG, Einhorn's triangle, Lead 1, Lead 2, Lead 3, Augmented Leads, and Precordial Leads. You have applied the electrodes and wires. How does the electricity in the heart translate to the EKG rhythm you see on your monitor? Before we move forward, we need to take a look back. So there I was in 1895. G.B. Selden had obtained the first U.S. patent for the automobile, or his version thereof at that time. The Lumineers, Augustine and Lewis, held their first private screening of the projected motion picture. And Dr. Wilhelm Einthoven invented the first practical electrocardiogram, or the ECG or EKG as we know it today, for which he received the Nobel Peace Prize in 1924. Einhorn's triangle utilizes a simple geometric figure, the triangle, to help us better understand leads 1, 2, and 3. Lead 1 is created with a negative up by the right arm or right shoulder and a positive up by the left shoulder. The camera view on an EKG is always at the positive lead. Lead 2 is created by a negative up by the right shoulder and a positive down by the lower left leg. The camera, again, is at the positive electrode. Lead 3 is created with a negative up by the left shoulder and a positive down by the right leg, with the camera facing the positive. We're going to get into the significance of the camera view very shortly. Let's look at lead 1. In lead 1, the net direction of the electrical impulses travel from the negative and moves towards the positive. Negative to positive, towards the lens of the camera, produces a P wave that is upwardly inflected in that lead on the EKG. In lead 2, the net direction of the electrical impulses travels from the negative and moves towards the positive. Negative to positive towards the lens of the camera produces a P wave that is upwardly inflected in that lead on the EKG. In lead 3, the net direction of the electrical impulses travel from the negative and moves towards the positive. Negative to positive towards the lens of the camera produces a P wave that is upwardly inflected in that lead on the EKG. Augmented leads are cross-sectional views of the heart's electrical activity. We're using cameras to make the concept a little easier to understand, and we hope it helps. AVR looks from the right side in a cross-sectional view. AVL looks from the left side in a cross-sectional view. And AVF looks from the inferior portion of the body up towards the bottom of the heart. So if you're having trouble understanding this concept, perhaps this slide will aid you. AVR is the picture, per se, of the electrical activity taken from a cross-sectional view from the patient's right side. AVL is a picture, per se, of the electrical activity taking place from a vantage point from the left side. And AVF is that taken from a vantage point as if the camera was on the ground looking up towards the bottom of the heart. So by this point in the presentation, you're probably asking yourself why we keep on talking about cameras. This isn't a photography course after all. Let's talk about contiguous leads and tie this all in for you. Lead 2, the camera is at the lower left leg looking upward towards the right shoulder area. Lead 3, the camera is down by the right leg and looks up towards the left shoulder area. In AVF, the camera is, let's say it's on the ground looking up at the bottom of the heart. If you notice, all three cameras are in the same approximate area, looking at the same approximate area of the heart. That's what makes them a contiguous lead. Most ALS providers have 2, 3, and AVF roll right off their tongue when they're asked about a STEMI. Inferior wall MI, 2, 3, and AVF. Now you know why. So you understand where the camera views are in 2, 3, and AVF. Let's see how this plays out on a 12-lead EKG. Let's look at 2, 3, and AVF. Even a novice provider will see that there is marked elevation in all three of these leads. But let's look a little closer. Let's draw a line from TP to TP and identify our J point. Yep, definitely elevation. 2, 3, and AVF, inferior wall STEMI. Reciprocal changes are those changes that you may see that are in an area that is opposite of where you are seeing the original issue. For example, in an inferior wall STEMI, the elevation is in 2, 3, and AVF. Leads that are reciprocal to 2, 3, and AVF are your high lateral leads. So let's talk about the lateral leads first. 1, AVL, V5, and V6. As you look at 1 in AVL, those are going to be the leads that you're concerned with primarily showing reciprocal changes in the face of an inferior wall MI. So as we look at the baseline and we look at the ST segment of 1 in AVL, we can see that there is depression in 1 in AVL. So this would be said to be an inferior wall STEMI with reciprocal changes in 1 in AVL. This illustrates the location of the precordial leads V1 through V6. Notice that all of the precordial leads are positive. So if leads 1, 2, and 3, which are bipolar, require a positive and a negative electrode, and AVR, AVL, and AVF, the augmented leads, are a byproduct of those positive and negative electrodes, and all of the precordial leads are positive, then where is the negative electrode or source for all of the positive precordial leads, which are V1 through V6? The answer is the negative electrode or source is generated by the cardiac monitor based on the placement of the other electrodes. There's no physical negative electrode attached to the posterior of the body. All precordial leads are positive and the QRS will transition between V1 and V6. Let's pause for a quick question and answer break. There is a net direction of electrical current in the heart. As that current travels toward the positive electrode, or the camera, it creates A, positive inflection in relationship to the isoelectric line, B, a negative deflection in relationship to the isoelectric line, C, neither a positive inflection or a negative deflection in relationship to the isoelectric line, D, none of the above are accurate. If you answered A, positive inflection in relationship to the isoelectric line, you are correct. V1 through V6 are blank leads, and view the electrical activity in relationship to which sides of the heart? A, bipolar, left atria and right atria. B, augmented, left, right, bottom. C, Eindhoven, RCA, LAD, LDCA. D, precordial, septal, anterior, lateral. The answer is precordial, septal, anterior, lateral. What is the best description of contiguous leads? A, leads that look at the electrical activity of the heart, but from completely different sides of the heart. B, leads that look at the blood flow in the inferior vena cava and superior vena cava. C, leads that look at the electrical activity in approximately the same region of the heart and from similar angles. D, leads that look at and measure the function of the valves of the heart. C, leads that look at the electrical activity in approximately the same region of the heart and from similar angles. If you can figure out where the camera lies, you will determine or understand the concept of contiguous leads. So in section 6, we will discuss bundle branch blocks, including right versus left bundle branch block, left versus right bundle branch block etiology, identifying STEMI in a patient with a left bundle branch block or a paced rhythm, concordance versus discordance, and Sgarbossa's criteria. Bundle branch blocks are simply delays in the electrical current traveling into the left or right ventricle via the left or right bundle branches, or both. You can have a left bundle branch block, a right bundle branch block, or what's called a bifascicular block. If you look at the illustration, you see traffic moving upward in the photograph, unimpeded, getting to its destination in a timely manner. You look at the next slide, there is a defect in the pathway. Now, in the heart, that could be caused by a structural defect, that could be caused by ischemia, little bits of blood getting to that area, or that could be caused by a complete occlusion of a coronary artery that's not supplying that node. So what you wind up having is alternate pathways going around, and on the EKG, it shows up as increased time, because we all know the fastest way to get from one point to the next is a straight line. So whenever you deviate from the original path, you'll still get to your destination. However, it'll take you longer. And that shows up on the QRS. Remember, reading from left to right is going to be time. That's why your QRS will be wider than 0.12. So all these cars over here traveling through the center of town, they're going to get to their destination, but it's not going to be as quick as going in a straight line. We're going to take a stop at this quick memory aid for right bundle branch block and left bundle branch block. If you look at V1 and V6 on the 12-lead EKG, you're going to notice that with a right bundle branch block, the majority of the QRS complex is upright or above the isoelectric line. If you were to compare that to the way you turn your turn signal on, when you move your turn signal in an upward direction, that activates the turn signals on the right side of your car. If you look at V1 and V6, the left bundle branch block, it gets a little bit more complicated. But V1 is predominantly downward from the isoelectric line. If you were to take your turn signal and push it in a downward position, it would activate the left turn signals. So this is a quick memory aid, but we're going to get into the pathophysiology of this, and hopefully you won't need it in the future. When the left bundle branch block, there's a delay in conduction on the left bundle just down from the bundle it is. This may be caused by cardiomyopathy, myocardial infarct, viral or bacterial infection of the heart, or chronic hypertension. The right bundle branch block is a delay in the conduction system of the right bundle, also just down from the bundle it is. This could be caused by a congenital anomaly, myocardial infarct, viral or bacterial infection, pulmonary hypertension, or a pulmonary embolism. So we'll start with what is supposed to be, or what is normal, in a left bundle branch block or paced rhythm. The total sum of the QRS should be moving in an opposite direction than the ST segment. This is called discordance. When the total sum of the QRS is moving in the same direction as the T wave, this is called concordance. Concordant ST segments and T waves in a left bundle branch block or a paced rhythm are considered pathologic. This is a Sgarbossa EKG criteria chart for left bundle branch blocks in determining if somebody is having a STEMI. This is based on a point scale, and if you've accumulated greater than 3 points, there's a 90% specificity of the person having a STEMI. So let's look at these three complexes. The first complex, we have our P wave, QRS. Here's the T wave going in the same direction as the QRS. So right here we see concordant ST elevation greater than or equal to 1 millimeter. That's 5 points awarded. The next complex is a P wave, QRS, and T wave going in different directions. So that's discordance. Let's find our J point. Second one says ST depression greater than or equal to 1 millimeter in V1 through V3. Gets them awarded 3 points. And the third one is your P wave, your QRS going in opposite directions as a T wave. That's discordance again. You find your J point if that is greater than or equal to 5 millimeters of elevation. That is awarded 2 points. You may be saying to yourself that these P waves look a little different. These P waves here are called biphasic P waves, and we can go into that a little later in the presentation. A new left bundle branch block is considered inclusion criteria for STEMI. However, how will a paramedic know if the bundle branch block is new or old? Well, it's unusual for a patient to have a copy of their previous 12 lead EKG. However, it's not completely out of the question this has happened. You can transmit the 12 lead EKG to the emergency department, which is going to be your receiving facility, and the staff of the emergency department may be able to look up a previous 12 lead EKG on file to determine if the changes are new or if they were present in a previous 12 lead EKG. Okay, we're going to pull this in for a quick question and answer pit stop. You're called to a local primary physician's office where a patient arrived complaining to his physician of chest pain. The physician shows you a 12-lead EKG and tells you the left bundle branch block on this EKG was not present on previous 12-lead EKGs. A, the patient can be transported to an emergency department without PCI capability. B, this patient's 12-lead EKG is inclusive for STEMI criteria with a new left bundle branch block. C, this patient should just go home and finish mowing his lawn. D, you should allow this patient to walk to the ambulance. If you have chosen B, this patient's 12-lead EKG is inclusive for STEMI criteria with a new left bundle branch block, you are correct. In this particular case, EMS was called to a primary care office to take care of a patient that was being assessed by their own physician. This happens quite frequently. patients either go to their primary's office or they may go to an urgent care that they visit often as they don't have a primary. And these facilities may already have the patient's previous 12 lead EKG on file. So what you do is you're walking out with the old 12 lead EKG, the new 12 lead, and the one you've taken, which is of huge benefit. You realize this is a new left bundle branch block. It's inclusive for STEMI criteria. The patient should be transported to the nearest PCI capable facility. C and D, if you pick that, sorry, you are incorrect. This patient should not go home and finish mowing the lawn, as that may be the last time they mow their lawn. And you should never allow these patients to walk to the ambulance, as walking or any additional exercise can create increased myocardial demand in the heart. And this may be what pushes them over the edge and sends them into cardiac arrest. The normal morphology of the QRS-ST ratio in a bundle branch block should be A, opposite one another, discordance, B, both in the same direction, concordance, C, neither opposite or in the same direction, hold clinical significance, D, mu. If you have chosen A, opposite one another, discordance, you are correct. Okay, don't get nervous, don't fast forward or delete this. We are going to discuss axis and axis deviation in section 7. It's a lot easier than most providers believe it is. We're going to discuss the source of axis and axis deviation, normal axis, right axis deviation, left axis deviation, extreme axis deviation, and then we're going to look at a couple of 12 lead EKGs and practice what we've learned. Most ALS providers will cringe a little bit on the inside when you mention axis or axis deviation to them. The general consensus amongst most EMS providers is, why does it matter and can I treat it? Axis and axis deviation understanding allows the provider to appropriately interpret certain EKG rhythms and 12 lead EKGs. It's an important concept and it could be an entire lecture in and of itself, but in this presentation, we're just going to touch on that. Axis is the average direction or electricity or depolarization. In this case, we're going to go over the axis of the ventricles. There are other axes that are able to be interpreted in the heart. But for this presentation, we're going over the axis of the ventricles. The normal axis is -30 to +90. And if you consider the net direction of electricity in the heart is considered lead 2, the majority of that electricity is going from your right shoulder down through the left side of your body. So now, if we put that on a scale, we're thinking that between 2 o'clock and the 2:30 mark is where our normal area will run. There are several causes for alterations in the normal axis, and these are cumulatively known as axis deviation. There is more than one way to interpret axis and axis deviation. However, we are going to go over one or two ways in this presentation. Most literature recommends utilizing lead 1, 2, lead 3, or AVF to determine axis or axis deviation. If you look at the morphology of the QRS in leads 2, 3, or AVF, with the exception of the physiological left axis deviation, the QRS morphologies are all equal in lead 2, lead 3, or AVF. So, for time management's sake in this presentation, we will be looking at lead 1 and lead 3. We recommend that you delve deeper into axis and axis deviation on your own and find a method that is comfortable for you. The normal axis is between -30 degrees and +90 degrees. Right axis deviation falls between +90 to 180 degrees. There are conditions that are associated with right axis deviation, including emphysema, loss of electrical conduction in the left ventricle, WPW, PEs. This may actually be a normal variant in thin individuals, right atrial enlargement, congenital heart defects, lateral myocardial infarct, tricyclic overdose, right ventricular hypertrophy, right bundle branch block, ventricular ectopic rhythms, and dextrocardia. If lead 1 has a predominantly downward-facing QRS from the isoelectric line, and lead 3 has a predominantly upward-facing QRS from the isoelectric line, this is considered right axis deviation. Left axis deviation falls between -30 and -90 degrees. Conditions associated with left axis deviation include high diaphragm pregnancy. It may be present in older adults, WPW, ascites, abdominal distension, including tumors or obesity, hyperkalemia, left atrial enlargement, emphysema, an inferior myocardial infarct, left bundle branch block, left ventricular hypertrophy, ectopic ventricular rhythms, or an implanted pacemaker. If lead 1 has a predominantly upward-facing QRS from the isoelectric line, and lead 3, or AVF, has a predominantly downward-facing QRS from the isoelectric line, this is considered left axis deviation. Extreme axis deviation, also known as northwest deviation, sits between -90 and 180 degrees. Potential causes are potential incorrect lead placement, electrolyte disturbances, cardiomyopathies, and ventricular ectopic rhythms. If lead 1 has a QRS that falls below the isoelectric line, and AVF or lead 3 has a QRS that falls below the isoelectric line, this is considered extreme axis deviation. 2 thumbs down. Using this printout, how do you think you could quickly determine the axis? Well, if you guessed that you could look at the PQRS-T axes and see it 79, 56, and 8 degrees respectively, you look at the QRS axes, and axes is more than one. Look at the QRS axis, 56 degrees. But you can confirm that by just looking down at the QRSs. They're upright in 1, upright in 2, upright in 3, upright in AVF. So that's a normal axis. Let's take a look at this EKG strip. In lead 1, the QRS is primarily above the isoelectric line. In lead 3 and AVF, the QRS is also above the isoelectric line. Some people remember this as 2 thumbs up. Thanks, Chuck Norris. This is considered normal axis. Let's look at this 12 lead. In lead 1, the QRS is primarily above the isoelectric line. In lead 3, the QRS is primarily below the isoelectric line. Normally, we'd be able to leave it there, but if you look at AVF, the QRS is actually biphasic. It's not really above or below the isoelectric line. This is left axis deviation, which is physiological. This is one of the few times where looking at both 3 and AVF make a difference. Let's take a look at this 12 lead. The QRS in lead 1 is primarily above the isoelectric line. The QRS in lead 3 is primarily below the isoelectric line, as with AVF. This is considered pathologic left axis deviation There's an issue with the structure of the heart that's causing this. If we look at the precordial leads, we are going to notice that there is a very large QRS. Remember, when you're looking at an EKG, left to right considers time, and up and down considers amplitude. The bigger the muscle, the bigger the inflection or deflection on the QRS. Consider the P wave, very small muscle, which creates a very small mark on the EKG, whereas the left ventricle, large muscle in comparison to the atria, large mark. But if you look at these QRS segments, they're very large. And this is a sign that there has been hypertrophy of the left ventricle. That is probably what is creating the left axis deviation in this patient. Let's take a moment to look at this 12-lead EKG. In lead 1, the QRS is primarily below the isoelectric line. And in lead 3, the QRS is primarily above the isoelectric line. This pattern is consistent with right axis deviation. Let's take a look at this 12-lead. In lead 1, the QRS is primarily deflected downward, as with lead 3 and AVF. This is considered extreme axis deviation. In this particular case, this is the 12-lead from a patient who has Dextrocardia. In Section 8, we'll discuss some specific causes for concern in the 12-lead EKG. That includes ST depression, ST elevation, and Q wave. Before you can determine if there is ST elevation or ST depression, you need to determine where you are measuring from. That will be the J point. The J point can be found by going down the isoelectric line, up and over the P wave, over the QRS, or in this case, the RS, and the point where it abandons the QRS segment into the ST segment is the J point. If you have trouble locating the J point that way, work from right to left, up and over the T wave, and at the point where it abandons the QRS or meets with the QRS, that is your J point. So we understand that we measure the J point to determine if it is elevated or depressed. But elevated or depressed from what? What is that line? If we expand this a little bit, you will see a white line. That line is created by taking the TP segment from one complex to the next and to the next and drawing a straight line across. I will highlight the TP segments in yellow so you have a better understanding. It is imperative that you create your reference line measuring from your TP segment of one complex to that of the next and the next. Do not use the PR segments as a basis to create your line. If you do so, you may erroneously feel that the ST segment is elevated, and this may affect your treatment options and even your transplant decisions. If you measure this appropriately, you would see that the PR segment is actually depressed. A Q wave is the first negative deflection after the PR interval. Not all QRS complexes have a Q wave. That would just be too easy. When abnormal, they indicate the presence of an ongoing or an old myocardial infarct. Pathological Q waves include the following criteria. They need to be present in at least 2 or more contiguous leads. The size needs to be greater than 25% of the QRS complex amplitude, and the Q wave duration greater than 40 milliseconds, one small box, except in the lateral leads, where the Q wave duration only needs to be 30 milliseconds to be deemed abnormal. Here are two examples, one of a normal Q wave and one of pathological Q waves. As you can see, this is less than 25% of the total amplitude of the overall QRS, whereas these Q waves are actually greater than 25% of the total amplitude of the QRS. Let's take a look at this case study. You're called to assist a 34-year-old female who presents to EMS after consuming 4 energy drinks, and her heart feels funny. She doesn't have any past medical history. She doesn't have any prescribed medication, no allergies to food, medicine, or latex. No major surgery reported. She doesn't smoke. She only consumes alcoholic beverages occasionally, and she doesn't consume drugs. It is important that you understand that there are drinks, pills, and food that can affect human health and create cardiac dysrhythmias and conditions in patients. This could be something that is perfectly lawful, such as caffeinated coffee or tea, or supplements that you can purchase over the counter, and include illicit drugs or supplements or pills that you can purchase online that have been banned in the United States. You obtain a full set of vital signs and a 12-lead EKG. So treatment options are beyond the focus of this presentation, so we're not going to go into specific treatment options. But we would like you to consider, does this rhythm need to be treated? Why or why not? How fast do you think you need to treat this cardiac rhythm? What will be the determining factors when choosing a treatment option? Is the patient stable or unstable? Does the patient require no intervention or medication? Or does she require electrical therapy, such as synchronized cardioversion? This is your patient's post-treatment 12-lead EKG. The patient reports feeling much better and tells you now that you fixed her, and she doesn't think she needs to go to the emergency department. Do you have any concerns? Could this patient be having an MI? Could this patient have an underlying medical condition causing her symptoms? Well, there are 3 words that EMS providers do not like to use. I don't know. And it's okay in circumstances such as these to say, I don't know, because EMS simply does not have the diagnostic tools to answer all of these questions for patients and to determine if they have what we would call a clean bill of health, so to speak. These patients should always be encouraged to let you take them to the hospital and be assessed at the emergency department. Which of the following is true about Q waves? A, the Q wave is the first negative deflection in the QRS complex after the PR segment. B, not all QRS complexes have a Q wave. C, Q waves are considered pathologic if they have a duration of greater than 40 milliseconds, one small box, and are greater than 25% of the overall QRS complex amplitude. D, all of the above are true. E, none of the above are true. If you have answered D, all of the above are true, you are correct. When creating the reference line to measure ST segment elevation or depression, the provider must use which segments of each complex as a reference point? A, P to P, B, ST to ST, C, TP to TP, or D, PR to PR. If you have answered C, TP to TP, you are correct. Some people get hung up on this and can't remember it. So here's a memory aid to help you out. ST elevation measures the portion of the EKG where the ST segment first disembarks from the QRS, called the A, P wave, B, J point, C, T wave, D, U wave. If you've answered B, J point, you're correct. What is the primary significance of ST segment elevation on a 12 lead? A, results from a complete or near complete occlusion of a coronary artery. B, results from a small or partial obstruction of a coronary artery. C, results from ischemia of the heart muscle. D, results from infarct of the heart muscle. E, all of the above are true. F, only A and D are true. If you answered F, only A and D are true. You are correct. A STEMI does not result from a small or partial obstruction of a coronary artery, yet results from a complete or near complete occlusion. It does not result from ischemia of the heart muscle, it results from infarct of the heart muscle. We hope that you enjoyed part 3 and maybe you have learned something. For others, this may just be a review of information you have already known. Please proceed to part 4, the final part in our presentation.